I'm Gary Nickerson.
And I'm Quinn Taggart.
And this is Outside My Window. A new pilot program has been launched in Nova Scotia that establishes new primary care clinics at select pharmacy locations. Now, these clinics provide extended services at no charge to people with a valid Nova Scotia health card. Mathieu Maltais is a pharmacist and owner of City Drug PharmaChoice in Yarmouth and Balsers PharmaChoice in Digby, two of the pharmacies selected for the community pharmacy primary care clinics. Darlene Mooney has been a pharmacist for 34 years and is pharmacy manager at City Drug. Welcome to you both.
Thank you.
So, Mathieu, tell us how your journey began. What led you to choose a career in as a pharmacist, and how did you come to own two drugstores in Western Nova Scotia?
Yeah, so I guess I've always wanted to be a pharmacist since I was young because it kind of mixed up healthcare and science with business. Because I had obviously a deep interest in business, so it kind of that's why I choose that career. And the reason that I'm in this region is mainly because my wife is from the region, and she brought me over. And when I had the chance to acquire City Drugstore, I couldn't pass it up, and the rest is history, I guess. It's been I bought it in 2011, 6 months after I graduated from pharmacy school. So in Balsers, I acquired in. Remember? 2017, I think. Yeah. So it's been 5-6 years for that one. Yeah. So that's kind of my story, how I came to be here and own those places.
Darlene, what made you decide to become a pharmacist in 34 years, and has it all been at City Drug?
It's been so long ago, Gary, I can barely remember why I decided to become a pharmacist, but pretty much the same reasons as Matt. I was interested in healthcare and liked dealing with people, and so I chose that as a career. And I started as a student my first summer after in pharmacy school, and I've been there ever since.
Darlene, if I can just ask a very loaded question, are there a lot of women in pharmacy, and was it like that when you started?
There is a lot of women in pharmacy. Back when I went to pharmacy school, it was 2/3 women, 1/3 men. And I think it's pretty much continues to be the same.
So, Mathieu, programs and pilot programs like this always seem to work very well with partnerships, and there's important partnerships in this between the Pharmacy Association of Nova Scotia, the province, of course, and the Nova Scotia Health. So talk about that in terms of getting this program off the ground and running.
So, I mean, this is something that pharmacists and pharmacies have been wanting to do for a long time. We just, we have more knowledge, I guess, than we've been traditionally allowed to apply in real terms. And I don't know exactly how the PANS, the Pharmacy Association, has been working for years to try to really push the envelope and get buy-in from all the different players in order to let us do that, and maybe also have some appropriate funding for us to be able to do this. And just recently with the state of healthcare in the province, I think there's been a big push by the current government to kind of really make some significant changes. And as far as this is concerned, it is pivotal. It is a huge step in the right direction. We have a lot to figure out still, and this ends the pilot project. And we have a lot of need to get the word out there that it's even a thing, because it's quite unique, and it is quite changing for the system here. The partnership with the government and PANS and the health department has been great. It's still very in its infancy. We launched City Drugstore, the clinic, February 1st. And Digby just launched last Monday. So we're still in the learning phase and trying to figure out how to deliver these services.
So, Darlene, what was the process that determined which pharmacies would take part in this pilot program? Was there an application process?
There was. Any pharmacy that was interested in participating had to put in an application. There were certain physical requirements that were necessary building-wise. We had to have 2 clinics to be able to deal with patients. We had to have the appropriate amount of staff because you basically need another pharmacist. We're 40 hours a week of pharmacist in the clinic only, so you needed enough staff to be able to provide the service, equipment, and so on. So there was a significant commitment to be able to put everything into place that required to be put into place.
What about training, Darlene? I mean, obviously, this is an expansion on roles and responsibilities, and even though Matthew said there was a certain amount of skills that weren't being put to use from before, but I would think that someone coming out of school right into the role wouldn't necessarily have that worldly experience necessary.
Right. Now, some of their clinical knowledge is right up to speed, but you're right as far as dealing with patients. We've got a really good team. We've got 4 pharmacists that are working the clinic on a regular basis, of all stages in their careers. But we have been doing, since we found out we were getting the pilot back last summer, we've been doing some online training. We've had to go into the city a couple of times to train on some other things. Now, some of the services are services that we've had within our scope for some time, just not been able to do it in such a structured format. But over the years, all these added services that we've been able to provide have just become too much to be able to just do on the fly when you're working in the dispensary. So that's why the program's kind of dividing the assessment prescribing part of pharmacy and the dispensing part of pharmacy. So they're being run as 2 separate entities. But our staff has been doing a lot of education. And continue to. We had another scope just last week that was added to our repertoire. So it's continuing to evolve.
What about added technology? I mean, when we talk about the sharing of information between pharmacies so people can't, multiple fill a script, it's one thing, but, certainly they're in the process of trying to find a programmer to go and update medical records through the hospital system as well. Are you guys all tied in with that? And what did that require?
So for some years, we've been able to log into drug information system. So, and all pharmacies can. So if someone gets a prescription filled somewhere, we're actually responsible. It's our liability to determine that medication isn't interacting with something that they're getting at another store. So that is part of what we're already able to access. For some years, we've been able to access blood work for medication management purposes. So if someone's coming in on a medication that we need to assess, their kidney function or something like that, that's also been part of our scope. But we'll continue to evolve with that. Matt's the guru of technology.
Yeah, I mean, so as far as the lab work, we were able to look at it, but we weren't able to order it, and now we can, which is pivotal again. And we had to take extra training to do this also. And now the other thing that is coming, and I'm not sure Darlene even knows yet, but there's going to be we're going to be a pilot site allegedly for the EMR being introduced in our site, and we have to figure out the kinks, right? Because we're really off-site. We're not a government site, so we have to. There's some technology challenges there. And I don't know a lot of details, but I think, logically, eventually we need to be part of the, there's a slogan, but it's like one patient, one record, I think. And then we want to be able to see the charting that other physicians and other clinicians are doing, and we want to be able to share our charting without having to fax it off, So
Well, it seems imperative. I mean, you've got 150,000 round numbers people right now that don't have a primary care physician. So, the logging of that information and the accessibility of that information in order for you to be able to make an educated decision is going to be critical.
yeah, I mean it's better healthcare because we're not repeating the same service, or we're not searching and doing history that's already been done, and we're not trying a strategy that's already been done. That kind of stuff, information is really critical in that sense. But it's a work in progress. We'll get there. For now, there's a lot of just good old communication. We call the clinicians, we talk to the patient, we do some faxing, we get it done. But yeah.
I mean, most people have seen or even have like a medical alert bracelet to let people know, hey, I'm allergic to penicillin or I'm diabetic or whatever. But I've seen technology incorporated into those as well, where it's like a flash drive that contains people's records or vital information or their list of prescriptions and the like. Is that something that's been kind of chatted about as an augmentation?
Not at that level, I don't think. It's even like for the pharmacy and the dispensary world, it just is recently becoming financially viable or doable, and the technology exists to have integrations within our software to do like an app for refills and for you to look at your profile. Like we've only introduced this at our drugstore like within the last year, right? It existed before, but it was very cost prohibitive. So those types of things are going to grow and are going to come in more. And I think that's what you're just saying there is a great idea, but I don't know that that's going to be something we're going to see in the next 5 years. It's a lot of the challenges that I've seen is that there is a lot of software, and these software don't necessarily speak to each other. And
well, that sounds like government to me.
Yeah. But like we live in a world that the pharmacies were dispensaries, and more the last decade we're becoming, in a sense almost we're providing clinical services. So we have to do charting, we have to do kind of like a doctor's office, right? And our technologies were not meant for that. So we're kind of in a way trying to fit a square peg in a round hole, but it's catching up. Things are improving, and when the technology fails, you can always use a pen and paper. So
I know that there was a online facility allowing people to go and check their blood work on their own, and then for whatever reason it went away. That the government didn't renew the contract. So what kind of scares me in this regard is that this is being put in by the government of the day. How secure is this going forward? Is this a long-term initiative that's got bipartisan support?
Yeah, I mean, as far as I'm concerned with that type of questioning, I guess it's I have this conversation with my staff a lot of times, and I don't do what ifs. I'm optimistic. So if not, I wouldn't be part of this pilot project, because there's a lot of uncertainty. Like, do I invest all this training, all this money into facilities, all these efforts into marketing and filling these clinics, and then the rug gets pulled from under my feet in a year? It's not impossible. It doesn't matter. I think ultimately, once the public sees the level of service we're offering, this is not going away.
I think it would be very career limiting on any politician's part to go and try to pull it out from this one.
And that's it. Like, I think we speak to the public, and we're going to do it with experience and with actually delivering the services. We have the opportunity, we have the opening right now to do it. And everybody that we've had so far have given us rave reviews. They're ecstatic of the quality of service, the service we're offering, the range of services we're offering. And honestly, for us, this is extremely rewarding.
Now, you mentioned rave reviews, and I always am a big fan of feedback direct from the source. Do you find that the clientele to this point is mostly going to be people that don't have a primary care physician? Or are you finding that you're getting some folks that, oh, my doctor's on holidays or his office isn't open today, but I need some help?
We're getting a bit of both. At the onset, very first days, it was a lot of people who hadn't seen a physician for a few years, needed prescriptions renewed, and so we're seeing from all over the place. Now we're getting more of the more urgent things, or the more needing to be dealt with today. So the UTIs, the strep throats, those kinds of immediate service that if they can't get into their doctor's office for 3 or 4 weeks, those are the kinds of things that we can deal with. So we're seeing all kinds of things.
Yeah, I mean, and I think like it's for people, the public, to wrap their head around what our service is. It's a little bit complicated, I guess, in a sense, because there's really 3 or 4 streams or windows of types of services we offer, right? So, and the groundbreaking ones is that we can now do chronic disease management for diabetes, hypertension, cholesterol, asthma, COPD, which means that we can prescribe whatever medication you need. We can change them. We can order labs. So we can do complete disease management. The only requirement, I mean, of course, for coverage, you need a health card, a valid health card, and you also need to have a diagnosis. So you need to know that you have the disease. We do not do screening, and we do not do diagnosing. So, but we can take over for somebody that knows they have diabetes, they don't have a physician, and they're chasing the outpatient or unattached clinics to try to get their refills, try to get access, and their disease is unmanaged. We can do that for them. And obviously what we will do is we see them repeatedly until we get them to a controlled level. And after that, we'll just renew their prescriptions once a year until, maybe someday they become uncontrolled again. Then we'll do more intensive interactions at that moment. So that's really chronic disease management is one type of service. The other type of service is minor ailments, right? Which is more like outpatient level things. They're one-offs. You have a heartburn, we can prescribe for that. You have, like Darlene just said, like the strep throat, the UTI, the shingles. They're like non-urgent things that you typically would go to outpatient for and wait a very long time. We can knock off a lot of those things. If we do not have to see you, we do it on the phone. We also have the potential, talking about technology earlier, to do virtual. So we can do like a Zoom call kind of deal. But if you have a rash for eczema or dermatitis, I need to see you. I need to look at the rash. So it depends on really the kind of service you're seeking. So that's another stream, I guess, the minor ailments. The third one is publicly funded vaccinations, which are like, I'm not talking about the clinics, the COVID clinics, the flu vaccines. We still do those, but so does all the other pharmacies. The difference here is that the vaccines that usually you'd have to go to public health for, we can now do them. So that's been added. Those are the big ones. And I guess to go back to technology again, and we didn't mention it earlier, but part of this clinic is that we have access to a series of testing machines, which, they're quite expensive, but they are lab tests, quality machines that we can do point of care testing. So for the things that we can test for is A1C, which is a blood level for diabetes. And the advantage is that I get an answer really quickly, and it's a finger prick. It's not a blood draw. The other one that's like that is a lipid panel or your cholesterol. We can do that. But for example, if you have a cholesterol pill, right? I need to look at your cholesterol, but I also probably need to look at your liver function. We cannot do liver function. So in that scenario, we would be filling out a requisition form and sending you to the hospital lab to get that one. The other test that we do on site is INR testing for warfarin. So, which again, the advantage is a finger prick. So if you are on warfarin and you need a minimum of a monthly test for monitoring your warfarin, you have to go to hospital. You got to pay for parking. You got a blood draw. You know, and sometimes it takes 6 weeks before you can get an appointment. Right? With us, you can book and you can get the finger prick.
Yeah. And our staff is trained to make dosage modifications as well.
So and we get the result on the spot. Right. Versus at the hospital is 24 hours turn around, I think, and then your physician or prescriber will get a note, and it's kind of a longer turnaround. Where with us is by the end of the appointment, everything's solved already. And then the other testing machine we have is for strep throat, which is a PCR level machine. It's not like some places had antigen strep for a while there. They were selling tests. It's not the same thing. And for strep throat, we do not automatically test you if you want to be tested. We have to do an assessment whether a test is warranted. And then if we test it and you're positive, then we can prescribe the antibiotic, right? So those types of things are extremely powerful. And we need like the public to know that it's a thing we can do. And Darlene just mentioned earlier that it brings me to this point, like whatever we say today, tomorrow is probably going to be more. So the best thing is to call us or check our website and to see what is current, what we can do. Because a couple of weeks ago, we can now take care of conjunctivitis, which is pink eye, right? Which we couldn't do before. So, you know, I keep our websites updated, like citydrugstore.ca or digbypharmachoice.ca. I have a clinic page on there, and if there's a new service, I'll make sure to put it on there. And while I have the attention here, the things that we cannot do, and we keep getting requests for, but we cannot do right now, is ear infections, chest infections, toe fungus, sinus infections. We can do allergic rhinitis, which is allergies of the sinuses, but not the infection. And we cannot order labs for the sake of ordering labs. So
it has to be part of the medication management process.
we need to do it because we need it for our job, not because you want to see what your labs are, right? So
Well, certainly over the last few years, the role of the pharmacist has changed drastically. And pharmacists have been given more responsibility as part of the overall, healthcare team. But this program has expanded those services even more. So how unique is this in terms of similar programs in Canada?
I think we're leading the way. We're pioneering the future of pharmacy, really. Each province does their own thing, but
the only other province I think that is maybe ahead is Alberta. I think it's Alberta. Alberta tends to do a lot of pharmacy services and more funding. But, every province has run this their own way. And I don't have the time or the energy, I guess, to educate myself on other provinces. But generally, I believe, like Darlene, that this is trailblazing.
The province has determined, I guess it's the province Department of Health, that this pilot program runs until April of next year. Is that correct? So, obviously, there's an ongoing assessment. How do you determine success in this program as far as your pharmacists are concerned?
so any pilot project involves a lot of data collection, and every single patient that we see, a form is filled out, how many minutes were used for each assessment. Like, there's a lot of data collection going on by the Pharmacy Association. They're speaking to the government on a regular basis to determine what's working, what's being used, where we go from there.
Yeah, I mean, I think, like Darlene said, like we are doing a lot of data gathering, but the Pharmacy Association has their team that really works on the analyzing that data. What their goal and target is, I'm not exactly sure, but I think we can all imagine what it's supposed to be. I mean, reducing stress on the other departments, right? The outpatient and the unattached clinics, those type of things. But the amount of volume of people we can help, even if the stress, it's probably not going to be enough, right? The reality is, everybody's overwhelmed anyway. But ultimately, I think the public and the taxpayer wins because we are just, doing a little part to increase accessibility. Something like running out of refills and having to go wait at outpatient for 12 hours is the thing of the past. The scenario where that is necessary right now with our clinic, I can't think of one right now. So, especially unless it's something that shouldn't be renewed, right? And we are still clinicians, right? We make an assessment based on the situation of the person. But if it should be renewed, we'll renew it. And the big barrier that other pharmacies have and we had is the ordering of the labs, because at some point I cannot keep refilling your prescription if some lab needs to be monitored. It becomes unsafe. So then we have to send you to the outpatient to get a lab because we couldn't order it, but now we can. So
and
that is
we're
solved.
happy to work with other pharmacies as well. If they have patients that they're at a standstill with, we'll help them move that process along.
Now, I know COVID threw a monkey wrench into a lot of different things and a very big ripple effect when it comes to healthcare in general. Was this pilot project, in your mind, a natural evolution of things, or do you think COVID kind of pushed it a little along so that it's here and now, as opposed to maybe further down the road?
Yeah, I don't want to get political, but I think the government change was part of it. I think what was happening in the news with the healthcare system was part of it. I did, a complete renovation of the pharmacy, and I had in my mind that I was building a clinic no matter what. This thing just appeared. I've been planning the renovation of the pharmacy for 5 years. And I've always had the intention of going clinical. I didn't know how the financials of it and how it would work, but this pilot kind of fell in our lap. It just so happened that I had the facilities lined up to be able to accept it. So it's I think it needed to happen. I think for us as pharmacists, we're talking about a decade of frustration here. So it gets to a point where we hope, but we assume it's not going to happen. So this was a great, really positive surprise. And that's why, I decided to jump on it. I didn't have the staff to do it. The things were not ready for this, but I decided to sign up anyway and figure it out because it needed to happen. And I think we're the right people to do it.
When you referred to COVID, I think certainly throughout COVID, once the rest of the world closed down and pharmacies were the ones that stayed open through the whole time, we did see changes being implemented along the way within our scope of practice to help facilitate things. So it might have been a door opening, but certainly this is
It pushed the virtual.
Yeah.
It did push the virtual. I mean, and they changed some laws around even the physicians being able to bill without the person sitting in the office. There's things that just made sense, and COVID kind of, made it come about faster. And for us, maybe that was part of it too. To be frank, our ordering lab, like being able to order labs, was passed into law 8 years ago, and we're still waiting for us to be allowed to do it, right? Actually, so I mean that's been a contentious issue between the pharmacists and the pharmacy association and the government for years, and still like we're it's only pharmacists in the pilot that can do it. So. I think it'll roll out to everybody else eventually. But there's definitely extra training needed. It is not something, and then the other concern that I think is understood is that if we add all these clinicians to the list of people that can order labs, can the lab can they handle it, right? So there's that too. But something like us doing the INR, we can definitely take that load off the lab. What the challenge that I've had so far is just to convince people to come to us instead, right? The conversations I've had with people is I get disbelief. I get this can't be this easy. You mean all I need is a finger prick? Is that a good test? Those things are that's the responses I get, but it is that easy, So, and we can take a lot more. So we're hoping that people will find out. Yeah.
Well, one of the advantages I see is that it's people we know. People know Darlene.
Yeah.
People know you. You've been here long enough to be
I don't know
known
if they
in the
know
community.
me. I'm good at hiding, but
But I think that adds a lot of weight to it in trying to encourage some of our, older population, of which I'll classify myself in there as well, to come through the door. Because there would be some skepticism. I know technology is kind of there and maybe it's evolved enough that it can handle it. But I don't know if that's, hey.
I think some of it too. The challenge that I've seen is especially older generations, they're used to what was the word, the patriarchy of the physician relationship, where they seek approval or they seek directions. They don't want to come to us for INR unless the doctor said so, right? Which is not a requirement, and really most physicians would be really happy that their patient is taken care of. It doesn't really matter how they're taken care of, right?
In this day and age of WebMD and online Googling, people are self-diagnosing in a lot of cases too. Even us older folks, I'll go online. I'll say, "Well, geez, I'm feeling like this. What could it possibly be?" And I'll go down through the list and I'll go, "No, I don't think it's any of that." But I know other people might look at that and go, "Oh my Lord."
Well, I mean, there's confirmation bias there, right? You search for what you want to convince yourself you have. That's you're typing in the search box. So you're typing for what you want, for what you're looking for. So it's, there's a conversation between experts. And I mean, pharmacists are experts in their field, right? It's an abundance of knowledge doesn't mean you know how to interpret it, right? Or how to read it, or how to put it into a real action. And then we've definitely seen that during COVID, right? And the all the information on social media and people reading studies. But I took 2 years of university and training to be able to read a study. Reading a study is not good enough. You need to be able to assess it and decide if it's a good study or a bad study, right? And those types of things. I think ultimately knowledge is fine, but you need to seek specialists or experts into the field to be able to really apply it to your case.
You have to have context. I mean,
Yeah.
in my day job, I deal with large volumes of data, but it's just data. I mean, and sure, multiple people could shape the same data differently. Just look at the weather forecast. They all have access to the same data, but you're going to get a forecast over here and a forecast over here that don't look anything like each other. So being able to add context to the data that you're seeing is really important. And I think that, for those folks that may not have a primary care physician, this is going to be a godsend.
Yeah, I mean, we believe so. They just have to find us, seek us out. And I mean, and the other thing that I'll say, like I spent the weekend at the home show, right? I've had over 100 conversations with people, because this is not a pamphlet worth of information. This is a conversation. It's not a simple thing to explain. It's not a slogan. It's just a lot. So I've had like over 100, and the theme that I've got out of it is that there's a lack of awareness. The people that know do not understand the extent of it. The extent of the services we do offer. Even so, I've had some people that use their services, and I said, okay, but do you know that we do all these other things? Oh, no, I had no idea. So, I mean, for me, it highlighted, internally, we need to do a better job at least educating the people that are in front of us, right? Getting the people at large to understand the whole concept is one thing, but at the very, very minimum, we have to do a better job at making sure that when you come to our clinic, you understand of all the things we can actually do and how to find that information, right? The other thing the other questions that I had a lot asked is like, okay, does it matter if I have a doctor? No, it does not, right? How much does it cost? It doesn't cost anything. You need a health card. That's it, right? We can't say that on the pamphlets because there's a few things that are not covered because they wouldn't be covered at the doctors either, right? If you need a shingles vaccine, it's not covered. If you need a travel vaccine, it's not covered, but we still do it. So those types of things aren't. And the other question that I got a lot of is like, oh, do you need to be my pharmacy? And no, you do not, right? And if you want to take your prescription elsewhere, we'll just send it wherever. We're acting like a prescriber, like a clinician. We are running the clinics separately. Of course, the pharmacy is right there, and we do prefer that you use us. Who wouldn't? But ultimately, we're not forcing anybody, and it doesn't restrict your access to our clinic. It's publicly funded. It's publicly available.
So if someone wants to seek services or assessment from one of these select community pharmacy clinics, and perhaps they don't normally get their prescriptions at that particular pharmacy, that's no problem?
That's no problem.
If a prescription is given, in that case, that would be shared with the person's pharmacy? Is that how that works?
Yeah, we may just give them a prescription, just like if you went to the doctor's office, they'd give you a piece of paper, or we could send it to the pharmacy.
Yeah, we can fax it. We can just, yeah. And everything shows up on the DIS after, but our process right now is sometimes it's easier just to print it and hand it to the patient and they can take it where they want. But we can also fax it off. And, you know, the way, and you were asking if they could book, and the way that it works is that we operate like a doctor's office, which is what people would most recognize. We have a secretary, a clinic admin, or is their official position. She answers the phone 9 to 5, Monday to Friday, at both locations, at Digby and Yarmouth, and she books you in for an appointment. The other, and it depends what appointment you want, but she does a bit of triaging, and if we don't think we can help you, we're not going to make you come in and waste your time, right? We do some triaging right on the phone. So if you're not sure, you give us a call, and we'll tell you right there. But we do run it appointment based only. We don't really have walk-ins, but every day we keep some openings for more urgent services, right? If you have a urinary tract infection, you don't want to wait 3 days. It's today. So we have openings for that. The same things for shingles and that kind of stuff. So, and on top of that, if it is a service that's offered at any pharmacy, well, we have our dispensary pharmacists there too. Most days we have 3 pharmacists on staff. So if the clinic gets overwhelmed, we can reassign some work to the dispensary if it's urgent. We also have the ability to refer you to our other clinic, right? So if the city drugstore clinic is filled up, it's happened this week already, but if it's filled up on a day and we need something done more urgently, then we check our Digby clinic, and can the pharmacist there, the clinician there, take care of it. If they have an opening, then it works when it's a phone call, right? If it's something we have to see you in person, then it doesn't work so good. But so there's a lot of potential. I mean, we're in the customer service industry, the pharmacies, right? We do customer service. We do healthcare, but we do it with a customer service background. So we want people to be happy. We want people to be satisfied, and we'll do it to the most of our ability. So it is I believe, a complete different experience for a patient, right? It's just different. And I would say, and the other way to book is to on a website. So we do have a website with booking options in there. You can look at the calendar, you can see the openings, and you can pick your slot, right? Not all the services are listed online because they're not all the same length. And so if it's not listed, then we want to talk to you. So, and if you do book an appointment online, most likely we're going to be calling you anyway to make sure you book the right thing. But it kind of gives you the option to look at the calendar and kind of reserve your slot, and we'll call you when we get a chance, kind of deal. So that's the different way. And like while I'm here, like I might as well say the phone numbers, but it's the City Drugstore Clinic has its own dedicated phone line, and it's 902-742-3570. And then the Digby Bolsters Clinic has 902-247-3108. I think I'm right. Yes, I'm right. So I've been writing those numbers a lot lately. Yeah.
And they can still be accessed through our pharmacy if people forget that number. You can call the pharmacy. We can patch you through to the clinic.
Yeah, we can transfer you.
What type of follow-up care is built into this pilot program? I'm thinking in terms of if the pharmacist determines a person may need to see a specialist or physiotherapy, something like that. How would that work?
So we don't really have within our scope the ability to refer to any specialists. We can refer to primary care. In which case they may be able to move it on from there, but we don't really have any connections to refer to specialists. We can help patients navigate the system a little bit and point them in some direction, but as of yet, that's not an option for us.
It's obvious a great deal of thought went into this. It's very impressive.
The Pharmacy Association's done a lot of work. There's things that are going on a day-to-day basis that are outside even of our knowledge, and they continue to communicate with multiple partners to determine what the needs are and how to best be able to make this work.
Traditionally, healthcare has been more of a reactive than a proactive side of things, right? So are there any mechanisms kind of baked into this a little bit to encourage people to be a little bit more proactive with their day-to-day health, a little bit more healthy eating, a little bit more exercise? I mean, other than the usual stuff that people like to hear. Oh, you got to lose some weight. Yeah, okay, it's not that easy. How do I do that at 58 and still, manage my day-to-day? But are there specific mechanisms built into this pilot project to help with preventative health care?
I mean, not really. I think you're talking about a really high-level Canadian healthcare system concept that doesn't really work that way. I think there's other countries in the world that maybe I think they base their payment for clinicians based on the success of their patients. So then there's a bit of a incentive to do more prevention. But I mean, there's things like we do help with smoking cessation, which I would say that is preventative, right? That would be a good example. But I would say also that when somebody has no physician or no clinician of any kind, and they have a disease that is unmanaged, they most likely will not seek help. And they will get worse and worse and worse until they do end up at the ER, and it's really too late. And in terms of cost to the system, those are astronomical, right? Somebody gets there with a heart attack or a stroke or something. I mean, and they should have been on a cholesterol pill 20 years ago, and they didn't see anybody, didn't have a person to take care of them back then. Then that's when the problem is. So I think for us, like just the fact that we can do chronic disease management it's huge, and it is, you can't measure it. You're going to know in 10 to 20 years when, the impact of this, because we'll be saving some lives and we'll be the things, but how do you measure things that don't happen? Right? We know, right? we need if the problem is that we see it all the time in the pharmacy, many patients, when they do not have a regular person they can access, a regular clinician, or they're struggling getting refills, or they have to go with outpatient for something that's non-urgent, it takes forever, they quit. They say, never mind, I'm done with this. And they stop refilling their meds. And even though they're really critical meds and the health really degrades, and then it gets to a point where it's a much worse situation to deal with. So, yeah, I think that's where your prevention is.
No, and that's a great point. That's a great point. Have you had any? I realize the program's young, but have you had any feedback from the hospital on reducing the amount of input from their end? I mean, the amount of people that are in there for just basic day-to-day stuff. Are you making a difference?
We're seeing patients that, coming in for refills that have gone to Emerge and they've been told to come to our pharmacy that
Yeah, we're getting some referrals from those departments. Yes,
there's still a lot of education to be done on that end. They don't all know what's available and what's not, but
it's and I think ultimately, and I believe, I don't know the details, but I believe there's a centralized triaging system in the works, which we'll be part of. Because that's really what's missing for us. So you need a guide for patients to know. Well, yeah, exactly. You need a way for them to know, depending on their specific situation, where they should better go access that type of healthcare. And our clinics need to be on that list, right? And because the project is so early, I think this stuff is not in place yet. So that's why, I'm really hitting the pavement and trying to create awareness, because it's just not there yet. We still have a lot of availability, and honestly, we should be turning people around with the amount of need that there is out there. So that tells me there's just a bit of a lack of awareness.
Gap in communication, yeah.
So as we mentioned, a long list of services in regards to physical ailments and illnesses. Well, what about mental health? Someone comes in under stress, perhaps depressed. What can the pharmacist do in terms of referral for mental health?
So we've been part of a program called the Bloom program even prior to the pilot. And it's a provincial program as well, or actually a national program. And what we can basically do with that, it's a medication management and patient navigation program for mental health. So if someone's on antidepressants, anti-anxiety medications, they're not getting the most out of their medication that they would like, it's not working as well as they would like, or if they're having side effects, we can help manage those things. We can change dosing, we can try a different product within that scope. We can help discontinue medications if they've been on, particularly benzodiazepines that sometimes people are on a bit longer than they should be. It's not easy to come off, so we can help with that process, and we can help them to find other resources to kind of help them along.
We had an opportunity to speak with Fraser Mooney, who's the communications advisor for Nova Scotia Health for the Yarmouth Regional Hospital, about how they're feeling about this new pharmacy care clinic.
It's still fairly early in the implementation of the pharmacy clinic model to have some hard data or hard stats that would indicate that it's having an impact on the wait list in the emergency department. But anecdotally, I've spoken to the emergency department manager in Yarmouth, as well as the site leader at Roseway Hospital in Shelburne, and there's a community pharmacy in the Shelburne area as well. And they know that the people going to those clinics would normally, if they don't have a family physician or a nurse practitioner or primary care provider, they would be showing up at the emergency department. So while it's still early, a little too early to say from a statistical point of view that it is having a positive impact, we know that it has to be, because those people are accessing primary care, accessing care at their local pharmacy when they normally, or, without any other option, would be coming to the emergency department.
Now, obviously, this doesn't replace primary care physician, but I mean, realistically, when you're looking at the volumes of individuals heading into the ER on a regular basis, do you have a sense of how many of those were just like rudimentary basic stuff, like renewing prescriptions?
Statistically, we know that people are coming to the emergency department for reasons that aren't emergencies. Certainly, we are dealing with EHS, ambulance calls, people with real serious life and limb, life and death types of situations, but there is a large portion of people who don't have a primary care provider or are having trouble accessing their primary care provider, who are coming to the emergency department for things like prescription refills, some minor ailments, some minor breathing difficulties. In this area, things like tick bites. These are all things that can be addressed at these new pharmacy community clinics, and so we're going to be seeing a relief, some ease in the pressure that has been happening in the emergency department for sure.
Anecdotally, do you see this as more of a solution in rural areas as opposed to urban areas?
At one time, I would have said yes. This was more of a concept that would benefit rural areas as opposed to areas like Halifax Regional Municipality, for example. But as we've been seeing in the last few years, and especially since COVID, when a number of providers have left the system for any number of reasons, they're experiencing the same pressures in urban areas that we're seeing in rural areas. Their emergency departments are just as crowded as they are in the rural areas, and so I think it's something that I think will have probably on a statistical basis, you might feel the impact, the positive impact in a rural area more, just because there's less, there's not as many options to access services. But I think as this concept of pharmacy-based community clinics rolls out across the province, it's going to have an improvement for accessing care, either rurally or in the urban areas.
A wealth of information out there in terms of this community pharmacy program. So how can folks access information, and how can folks book an appointment?
Check our website, citydrugstore.ca. All our contact information is there. You can book online. You can call the clinic, 742-3570. Pharmacy in Digby has Balser's Pharmacy.
It's digbypharmachoice.ca. and 247-3108.
Ask. We're waiting for you to ask. Just call, pop in. Again, it's not a drop-in clinic, but we can certainly help to determine what your needs are and how we can best help you.
This has been fantastic. I can't thank you each enough. And Quinn and I definitely will be following up with you in, a little less than a year's time. Darlene, Mathieu, thanks again.
Thanks for having us.
Thanks a lot.
I'm Gary Nickerson.
And I'm Quinn Taggart.
And this has been Outside My Window.